In the face of rising global cancer rates, one modifiable risk factor remains strikingly absent from the standard cancer care paradigm: obesity. While cardiologists and endocrinologists routinely address weight in the management of heart disease and diabetes, oncologists have been slower, often markedly so, to confront the role of excess body fat in both cancer development and progression. This gap is not merely academic. It is costing lives. Obesity is now firmly established as a direct risk factor for at least 13 types of cancer, including breast, postmenopausal, endometrial, colorectal, liver, pancreas, kidney, and ovarian cancers. Beyond increasing risk, obesity negatively affects cancer treatment efficacy, raises the likelihood of recurrence, and significantly lowers survival. And yet, weight management remains peripheral if addressed at all in most oncology clinics. This omission represents a critical failure of integration between cancer prevention, treatment, and survivorship care. Oncologists can no longer afford to treat obesity as someone else's domain. The urgency stems from both biological and systemic realities. Biologically, obesity fuels cancer through a web of interrelated mechanisms: chronic inflammation, elevated insulin and IGF-1 levels, hormonal imbalances like estrogen excess, and dysregulation of cellular growth pathways such as mTOR and PI3K/ACT. Adipose tissue is not a passive storage depot. It's an active endocrine organ that alters the tumor microenvironment and immune response. These effects do not stop once cancer has been diagnosed. They continue throughout treatment, often exacerbating side effects, reducing drug responsiveness, and complicating surgical recovery. Patients with obesity often face higher rates of chemotherapy toxicity due to altered pharmacokinetics, and radiation planning becomes more complex due to excess tissue. Certain therapies, including immunotherapies, may also work differently in obese individuals, though research is still evolving. What's clear is that untreated obesity can erode the effectiveness of even the most advanced oncology regimens. In such a context, not addressing weight is not a neutral choice. It is a clinical oversight with potentially grave consequences. Despite this, weight management is rarely part of oncology workflows. Many oncologists feel untrained or unequipped to address obesity, often citing time constraints, lack of nutrition support services, or fear of stigmatizing patients already navigating a life-threatening illness. Others may believe it's too late to intervene, focusing instead on the immediate battle against tumors. But this thinking misses the broader arc of cancer care. Weight gain is common during and after treatment, particularly for hormone-driven cancers like breast and prostate. Without structured support, patients may enter survivorship at higher risk for recurrence, secondary cancers, and comorbidities that compromise quality of life and long-term outcomes. Moreover, the psychological burden of cancer often intersects with disordered eating, reduced activity levels, and depression, creating a perfect storm for further weight gain. Oncology teams are in a unique position to break this cycle. If addressed early and sensitively, weight management can empower patients, reduce complications, and reinforce the idea that cancer care is not just about killing cells, it's about restoring health. Survivorship is not merely surviving. Clinical guidelines have begun to shift. Organizations like the American Society of Clinical Oncology, ASCO, and the European Society for Medical Oncology, ESMO, now acknowledge obesity as a cancer risk factor and call for more proactive management. But implementation lags behind. Few cancer centers offer dedicated weight management programs, and referrals to dietitians or lifestyle counseling are still the exception, not the rule. Electronic health records rarely prompt discussions about BMI or waist circumference in oncology settings, even when evidence supports their prognostic value. What's needed is not just awareness, but system-wide change. Oncologists must be trained to discuss weight without judgment, understand its role in cancer biology, and coordinate with multidisciplinary teams that include dietitians, physical therapists, and behavioral health experts. Weight should be tracked routinely, just like tumor markers and scan results. And weight gain during treatment, especially in cancers where it worsens prognosis, should trigger intervention, not dismissal. Importantly, this call to action is not about blame or aesthetics. It is about improving treatment response, reducing recurrence, and extending survival. It is about recognizing that cancer does not occur in isolation from metabolic health, and that the best outcomes depend on treating the whole patient, not just the tumor. The rise of obesity-linked cancers globally makes this integration even more urgent. In younger populations, where obesity rates are climbing rapidly, we are already seeing an increase in early-onset colorectal and endometrial cancers. If oncology does not evolve to include weight management as a standard component of care, the burden on patients and health systems will only grow. Cancer care is entering a new era, one that demands personalized, holistic treatment strategies. Obesity is not a side issue. It is a central player in the cancer landscape. Oncologists must move beyond the tumor and into the terrain of lifestyle, inflammation, and metabolic disruption. Only then can we deliver care that is truly comprehensive and give patients the best possible chance not just to survive, but to thrive.